Good morning, good afternoon, good evening, and welcome to this second seminar, the role of geriatric and gerontology in the implementation of the decade of healthy aging. I will take the opportunity again to thank the organizers of the World Congress of the International Association of Geriatrics and Gerontology for the opportunity. And remember again that we have a very close relation from WHO with the EAGG, and we have been developed a strong partnership, and several of the product and scientific results that we will show during this panel presentation were developed with the participation of many members of the EAGG. This panel will highlight the discuss of the role of geriatric and gerontology on activities that are related to the implementation of the 4 action areas of the decade of healthy aging, 2021-2030. The decade, as you know, was approved for the World Health Assembly of WHO in August 2020 and was ratified by the United Nations General Assembly in December 2020. The official launch of the decade was in the October 1st in the last year, 2021. As you know, the decade defined 4 major priority areas. The first one is changing how we think, feel, and act toward aging and health. Age and aging, sorry. The action area 2 is about age-friendly environment and developing communities in a way that fosters the ability of older persons. The third one is how we will improve the delivery of person-centered integrated care and primary health service responsive for older persons or to older persons. And the fourth area is providing the older people who need with access to the long-term care. We, to do the explanation of these 4 areas and the participation of the geriatric and gerontology in this matter, we have 4 very important presenters today. The presenter for action area number 1, changing how we think, feel, act toward age and aging, is Dr. Chris MIKTON, Technical Office of WHO Demographic Change and Healthy Aging Unit, and one of the lead actors of the UN Global Report on AAs published in 2021 and recently launched in the Spanish and Portuguese version in the Americas. Dr. MIKTON, you have a floor.
Hello, everyone.
So I'm going to talk to you about ageism. The first of the 4 action areas of the decade. Change how we think, feel, and act towards age and ageism. The reason ageism is the first action area of the decade is that despite the many contributions of older people to society and their wide diversity, negative attitudes about older people are common across societies and are seldom challenged. Ageism also imposes barriers in policies and programs in sectors such as education, labor, health and social care, and it influences the way problems are framed, the questions are asked, and the solutions which are offered. Ageism, therefore, marginalizes older people within their communities, reduces access to services, including health and social care, and limits the appreciation and the use of the human and social capital of older populations. World Health Assembly Resolution 69.3 called for a global campaign to combat ageism, which I'll tell you more about in a minute. And the aim of this campaign is to create a world for all ages by changing how we think, feel, and act towards age and aging. In early 2021, we launched the Global Report on Ageism. This report summarizes the best available evidence on ageism. It outlines 3 strategies to address ageism, and it includes 3 recommendations for action. Age is one of the first characteristics, along with gender and race, that we notice when we interact with others. It is one of the main bases on which we categorize people. Ageism refers to how we think, stereotypes, how we feel, prejudice, and how we act, discrimination, towards others and ourselves based on age. We're not born ageist, but it starts early in life and then it's reinforced over time. Children as young as 4 years old are aware of their culture's age stereotypes and prejudices through things like storybooks, the media, family culture. Then these stereotypes are internalized and used to guide our feelings and our behavior towards people of different age groups and to ourselves. Thinking older people are a burden on society is an example of an ageist stereotype that discounts the many contributions older people make. Not being able to work because of your age, maybe because of mandatory retirement laws, or being denied a job, or being denied healthcare based on age, are forms of ageist discrimination. The report, the UN Global Report on Ageism, found that ageism is everywhere. Ageism affects people of all ages, and ageism exists in our institutions, in our relationships, and ourselves in the form of self-directed ageism. A study in 57 countries found that 1 in 2 people, or half the world's population, have moderate or high ageist attitudes against older people, with rates much higher in low-income countries, as you may be able to see on this map. For younger people, we have more limited data. In Europe, the only region for which data is available on all age groups, studies have found that older and younger people report the highest rates of experienced ageism among all age groups in the regions, as you can see on this chart, with younger people, left here, reporting more age discrimination than any other age group. The report also shows that ageism is harmful and costly. It has far-reaching impacts on all aspects of people's health, their physical health, their mental health, and their social well-being. Ageism intersects and exacerbates other forms of disadvantage, including those related to sex, race, and disability. And ageism takes a heavy economic toll on individuals and on society. But the overarching message of this report is an optimistic one. We can combat ageism. 3 strategies work to reduce and eliminate ageism. The first of these is policy and law. These can address discrimination and inequality on the basis of age and protect the human rights of everyone, everywhere, at all ages. The second strategy that has been shown to work are educational activities, which can enhance empathy, dispel misconceptions about different age groups, and reduce prejudice by providing accurate information and counter stereotypical examples. Such educational interventions can be included in all types and all levels of education. Third type of strategy supported by good evidence are intergenerational interventions, which bring people together of different generations, and they can help reduce intergroup prejudice and stereotypes. These are among the most effective interventions to reduce ageism against older people, and also show promise for reducing ageism against younger people. where possible, we need to implement these three types of interventions together to maximize impact. The report concludes with three recommendations for action. The first is to invest in the three evidence-based strategies to address ageism I just described. The second is to improve data and research to gain a better understanding of ageism and a better understanding of how to reduce it. And the third is to build a movement to change the narrative around age and aging. And to achieve the last of these recommendations, building this movement, we've also launched the global campaign to combat ageism. This is an initiative supported by 194 member states, and it has three aims. First is to generate evidence on ageism to better understand what it is, why it matters, and how it can be addressed. The second aim is to build a coalition to improve data collection, share knowledge, and coordinate the prevention and response to ageism. And the third is to raise awareness to transform our understandings of age and aging. Thank you very much. And you can find more information on the campaign. You can find copies of the reports in different languages, including Spanish, and our other activities at this link here. Thank you. Bye-bye.
The second presenter, action area number 2, age-friendly environment, developing communities in ways that foster the abilities of older persons, is Dr. Thiago HERICK, Technical Offices of WHO Demographic Change and Healthy Aging Unit, and leading the work to create sustained age-friendly environment, including through the global network of age-friendly cities and communities. Dr. HERICK, you have a word.
Dear colleagues, I would like to thank you for attending this symposium today at the IAGG. My name is Thiago HERICK, and I will be presenting on age-friendly environments, which is the area of work I am responsible for here at WHO headquarters. And I would like to start by reminding us that while we are living longer, we unfortunately have not made the same gains in healthy life expectancy. And that is to say that a healthy aging is far from a reality for most people across the globe. And one of the important reasons for this has to do with the urbanization process we have experienced and are experiencing across the globe. We know that more and more older people are living in urban areas thanks to the world's rapid urbanization. And in this sense, we do have to account for an urban development that supports healthy aging, while also ensuring that rural and remote communities are not left behind, especially because of the inextricable interlinkages between these areas. Anticipating and responding to those major trends, rapid urbanization and population aging, WHO released back in 2007 the Age-Friendly Cities Guide, and in 2010 established the first steps of the Global Network for Age-Friendly Cities and Communities, which you'll hear more about in a minute. Those developments contributed to inform the discussions around the adoption of the Sustainable Development Goals back in 2015, supported the incorporation of aging considerations in the New Urban Agenda in 2017, and of course, strongly influenced WHO's strategy and action on aging and health. In 2017, the Global Network has reached over 500 members, and in 2020, a lot of this work has contributed to inform the development of the United Nations General Assembly Decade of Healthy Aging, 2021-2030. As you know, one of the key action areas of the decade is precisely to ensure that communities foster the abilities of older people. So creating age-friendly environments is therefore one of the top priority areas globally in order to address population aging and improve the lives of older people, their families, and communities. But what is then an age-friendly environment? Well, age-friendly environments are environments that foster healthy and active aging by building and maintaining intrinsic capacity across the life course and by enabling greater functional ability in someone with a given level of capacity. As you see in this image, we have 5 domains of functional ability, which is to contribute to society, to build and maintain relationships, to be mobile, to learn, grow, and make decisions, and of course, to meet basic needs. And here it's important to highlight that when we refer to environments, we do not only mean the physical or built environments, but rather all the factors in the extrinsic world, body out, that form the context of an individual's life. And that includes, for instance, the built and the natural environments, but also the people, their relationships, attitudes, and values, the health and social policies, the systems that support those policies, and the services that these systems implement. Practically speaking, let's imagine then the journey of this old person from his or her house to the food shop. Is this house accessible? Does he or she have access to different forms of transport? Is the neighborhood walkable, cyclable, pleasant, safe, clean? Are there benches to rest or public toilets on the way? Is the shopkeeper helpful and friendly towards older people? Does this older person have sufficient income to buy food in the first place? So as you see, all those practical elements form the basis on an environment that is good for people to age well, and also for their families and communities. Now, as part of the decade, there are several activities that we need to do to advance on this agenda. And that includes, of course, developing strategies to determine the effective action to foster age-friendly environments, to encourage cities and communities to join the global network, to learn from others, and to start on their journey to become more age-friendly. And I invite you all to be advocates of the global network, to use existing guidance on age-friendly cities and communities, and case studies on age-friendly practices, to encourage the establishment of national level networks, because we learned over time that they tend to be larger, stronger, and more sustainable, to support the capacity building of national and local leaders, and of course, to improve the evidence base around age-friendly environments. Well, I mentioned the network before, and I'm very proud to say that the Global Network for Age-Friendly Cities and Communities today has over 1,300 cities across 47 countries, covering virtually 300 million people. And we also have 17 very strong and committed affiliates at national, regional, and international level, without which the work of the Global Network wouldn't be possible. The mission of the Global Network is to enable cities and communities around the world to become more age-friendly by inspiring change, connecting them, and providing the technical support that they need to advance on this journey. Now, who can join? Any city, community, or subnational level of government that is part of WHO 194 member states. The application can be done directly on the platform, and you have the link here available, and it can be done in French, Spanish, and English. And basically what it takes for a city or community to join the network is the formal commitment from the mayor, from the local authority, the use of a common methodology, which I will explain in a minute, and the sharing. Make sure that you are an integral and active part of the network, including the submission of at least one age-friendly practice per year. The age-friendly practices are fascinating, and I invite you all to have a look of the existing platform that we have on great and inspiring examples led by people, cities, and communities from around the globe taking action to create age-friendly environments, sharing their knowledge, identifying common interests, and inspiring others. Now, How is that then we create an age-friendly city or community? There are many different ways. There's not a single recipe, and that has to be adapted to the local level. But certainly, one aspect that I would like to highlight here is that creating an age-friendly city or community is by no means a lonely exercise, neither a one-off activity, but rather a journey of continuous development. And because we know that older people know very well what they want and need, we need to make sure that they are at the center of any age-friendly city or community approach. So it is important to ask them about the opportunities and barriers they encounter in their community, to identify what prevents them from engaging as fully in community as they might wish to, and of course, to make sure that they are meaningfully involved in the decision-making processes that affect their lives. We now have members of our community, such as Melville in Australia, going to their 5th cycle towards becoming more age-friendly. So as you see, this is a very iterative process with older people at the center. And the steps taken come from a very successfully tested and proven framework that you see in this slide that has been applied in different contexts and communities across the global network, including in Latin America and Argentina, which go from engaging and understanding the reality, the local context, planning for action, implementing that plan, and then measuring afterwards, not only to monitor progress, but also to inform the next cycle in the implementation of these approaches for developing age-friendly cities and communities. And I would like to highlight here as well that under WHO's Age-Friendly Environments Mentoring Program, we have just completed a capacity building with the basics, to bring on board new and emerging leaders on age-friendly environments. And every single aspect that you see here, we received a great amount of interest with over 350 registered participants confirmed from 55 countries in all WHO regions. And we are now planning to replicate, to expand the same training to Spanish and French. Last but not least, I would like to highlight here some of the aspects that I feel could be the role of geriatrics and gerontology for age-friendly environments. So I bring here some of the suggestions on how this very important community could be on board and contribute to delivering on this vision. And that ranges from developing and monitoring a personalized care plan for older people based on the assessment of their needs and aspirations, but also on the environments they live in. I also invite geriatrics and gerontology members to help build the capacity for health literacy and age-friendly environments amongst other professionals and communities beyond the health community through knowledge exchange, training, and mentoring. Be ready also to learn from these different groups. Now, we know that urban planners, transport planners, architects, designers, business people, they are all part of this conversation, and we have a lot to learn from them. Engage with other people to learn about the age-friendliness of their environments and contribute with your health professional skills and expertise to improve these environments. Help build the evidence to make them better environments for us all to age, but also to make best use of the credible voice of the health sector to create demand for healthier policies, services, and interventions outside healthcare. Of course, build on the convening power of the health sector to merge relevant agendas and bring on board new partners and collaborations to create age-friendly environments. And then finally, to help provide age-friendly environments as an aspirational vision for a region, a city, or a country, and advocate for having every city and community striving to become more age-friendly. I would like to end up with some of the selected resources and guidance for those interested to know more, which are all available in the link that you see in this slide. I thank you once again for this opportunity, and I very much look forward to the continuation of these discussions today. Thank you very much.
Presenting action area number 3 delivering a person-centered integrated care or primary health service responsive for older people will be Dr. Yuka SUMI, which is medical officer and responsible for integrated care of older persons at the Aging and Health unit in WHO.
Thank you very much for this opportunity to present the critical role of geriatrics and gerontology in one of the action areas of Decade of Healthy Aging, deliver integrated care and primary health services responsive to older people. My name is Yuka SUMI. I'm a medical officer in Aging and Health Unit, Department of Maternal, Newborn, Child and Adolescent Health and Aging in WHO headquarters, Geneva. Primary health care is considered as a cornerstone of sustainable health systems for the achievement of universal health coverage and sustainable development goals. Achieving universal health coverage is one of the targets the nation of the world sets when adopting the SDGs in 2015. Universal health coverage means that all individuals and communities receive the health services they need without suffering financial hardship. It includes the full spectrum of essential quality health services from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course, including older people. The vision of primary health care is whole of society approach to health that equitably maximizes the distribution of health and well-being by bringing together three interrelated and complementary components. First, integrated health services with an emphasis on primary care and public health functions. Second, multi-sectoral policy and action. And third, empowered people and communities. Older people are frequently faced with numerous healthcare workers may be involved with one person's care, and many existing health systems manage health issues in a fragmented way. There is a lack of coordination across care providers and settings, which may lead to polypharmacy. Healthcare and social care are typically fragmented from one another. Older people find it difficult to use services even when they are available because of the cost of the visit, the absence of transportation, or the inability to pay for transportation. When they manage to access services, they encounter negative attitudes of the healthcare providers. Declining in physical and mental capacity, which is, we call it intrinsic capacity, is expressed very frequently as common impairment. For example, I cannot hear well or see well, I forget things more often, or have difficulties with walking. These problems are often overlooked and interpreted as signs of normal aging by healthcare professionals, although this is critical if they are to be reversed or delayed. The majority of healthcare professionals lack guidance or training to recognize and manage impairment in older age. There has been a lack of interventions provided to optimize intrinsic capacity and functional ability. All health and care workers need to be able to detect decline in intrinsic capacity and deliver effective interventions to prevent and slow its progression towards negative outcomes associated with care dependency. That's why integrated care is important to help older people maximize their intrinsic capacity and functional ability. Integrated care for older people reflects a continuum of care that will help to reorient health and social services towards a more person-centered and coordinated model of care. Since 2017, we have developed the integrated care for older people approach and a set of implementation tools such as framework and clinical care pathways. These ICOP tools aim to support policymakers, health and care workers, and communities to ensure person-centered care that addresses the diverse needs of older people. As you can see in the ICOP implementation framework figure on the right side, it is critical to think about older person at the center and work and coordinate all three levels from micro clinical level, meso service level, and macro system levels together in order to integrate the ICOP approach in the existing health and social care system and service delivery. There are 13 evidence-based recommendations available to manage decline in intrinsic capacity that include multimodal exercise, dietary advice and oral supplemental nutrition, provide routine screening for visual impairment, screen hearing and offer hearing aids as needed, offer cognitive stimulation, provide brief structured psychological interventions, as well as how to manage urinary incontinence, prevent falls, and provide caregiver support. Here is the one case example, the 75-year-old woman with hypertension. She might get the pneumonia, requires acute care, but still she can maintain the intrinsic capacity and the functional ability. After the hip fracture by fall, she might require walking aid to compensate her loss of mobility. And the cognitive decline actually requires home modification to prevent falls. And then when the person has a significant loss of capacity, she might need palliative care or assistive care and caregiver support. But during this trajectory of the intrinsic capacity and the functional ability, important thing is promotion and prevention of declining intrinsic capacity to be provided on the yellow side, as well as management of underlying health conditions, care coordination, and social support are critical too. The point in this figure is it is critical to provide a continuum of care based on their diverse needs. The ICOP approach provides a five-step person-centered assessment and care pathway, starting with screening for loss in intrinsic capacity. And then if the person has a positive in the screening, person-centered assessment in primary care should be provided. And that is critical that we understand and respect the values and preference and goals. These person-centered assessment includes not only the intrinsic capacity, underlying diseases, physical and social environments. Then design a personalized care plan with a person-centered goal, involving multidisciplinary team, supporting self-care and self-management. Although we are promoting integrated care approach in the community and primary care, it is critical to ensure the referral pathway and monitor the care plan that include referring to the geriatric care. We also need to engage communities and provide caregiver support. Here is the proposed role of geriatrics and gerontology for the integrated care and primary health services. Assess diverse needs of older people and develop and monitor a personalized care plan as a part of multidisciplinary team. Provide a specialized care as a geriatricians, for example, how to manage multi-comorbidities, incontinence, delirium, polypharmacy, falls, significant loss of intrinsic capacity. You could take a leadership role in capacity building of multidisciplinary health and care workers on the integrated care for older people among different care levels and settings. you could facilitate and coordinate the continuum of care through different settings and across health and social service delivery. We also encourage to build the further evidence on trajectory of intrinsic capacity and the functional ability, and how integrated care can maximize this capacity and ability. You could conduct ICOP implementation pilots, which is happening everywhere in the world, with local stakeholders in your country. And also, this is important to advocate person-centered approach. You can find more about ICOP implementation pilot program findings from the ready phase recently published by WHO. Thank you very much for your attention.
And our fourth and last presenter today, presenting the action area number 4, providing older people who need in access of long-term care, will be Dr. Hyobum JANG, Technical Office responsible for long-term care at the Aging and Health Unit in WHO.
As you are very well aware, providing older people with access to long-term care is one of the 4 action areas of UN Decade of Healthy Aging. To enable these action areas, there are a few important enablers, such as hearing voices and engagement of older people, families, and communities, which is really crucial, we think, to achieve these targets and actions. Why long-term care would be needed and crucial at this moment? You know that approximately 2/3 of people who achieve old age will probably need care and support from others to perform their activities of daily living, to be independently living. This number is already high, but it's going to increase rapidly in the future with population aging trends. And it's not just about a problem in high-income countries, but also significantly increasing in low and middle-income countries. And with this aging situation, the traditional caregivers, families, are not going to available or possible to provide all the care they need, and they cannot meet the needs of all the people, their family members. So long-term care, a proper long-term care system is essential and needed to ensure that all the people with limited functional ability can still enjoy healthy aging. And we advocate and insist that there is an urgent need to develop integrated and sustainable long-term care systems. We have reviewed and identified the typical challenges in long-term care, which many countries are facing. Governance is very complex, uncoordinated, and fragmented between different sectors, providers, and players in the country. There's a wide misperception that long-term care is too costly for the governments or payers, and would be endless that all the people and cannot contribute to the economy. And there are typically not enough formally trained or paid care workers or professionals to provide these services on long-term care to the growing population of older people. So there's a mismatch between demand and supply. And so far, most care depends on unpaid or informal caregiving. The carers are mostly women, family members, or volunteers in the communities, and they have to work and provide care without formal training. This provision of health and social care services is not integrated, but instead is very fragmented and coordinated between different sectors and service providers. So, in this decade of healthy aging, using this political momentum and high-level opportunities, WHO Secretariat, working with other UN agencies, have set target actions to achieve this 4th action area on long-term care. They include providing technical support for national situation analysis of long-term care, as we don't necessarily understand and know exactly what's happening in countries, what the situation are for all the people and carers. And as a technical agency, we are planning to design tools and guidance, especially for minimum package of long-term care as part of universal health coverage, which WHO has been advocating so far. And of course, because informal caregiving and the carers' needs are very essential, we are of course going to provide resources to support them. And we are going to explore many different tools and cases of delivering long-term care or financing long-term care, especially in low and middle-income countries, as the current knowledge and evidence is quite well established in high-income countries, but we need to support more low and middle-income countries. And for that, we have to document best practices and provide guidance on long-term care models. We recently have published an integrated continuum long-term care framework, which benchmarks on the famous WHO's building block approach. So instead of using 6 building blocks, we are suggesting 6 core elements of long-term care system, from governance, sustainable financing, workforce service delivery, information monitoring, evaluation, and innovation and research. You will find what would be the ideal long-term care system and what kinds of elements and actions should be in your long-term care system in the country level. So this WHO's long-term care framework is envisioning that services should be person-centered, coordinated, and the system should empower all the people and carers, ensuring their dignity and autonomy. Continuum care should be provided with integrated and should address specific needs of all the people and carers. Of course, integration between health and social care systems is crucial. Long-term care services should be accessible and affordable and should be part of achieving universal health coverage of a country. All the people's preference on where to stay or receive long-term care services should be respected, and aging in place should always be advocated. Long-term care by nature is and should be multidisciplinary and intersectoral. And there is huge focus on support for unpaid informal carers and their labor and their needs. Following this framework, we are currently working on so-called WHO's long-term care service package. This is a minimum list of interventions which should be prioritized within National Universal Health Coverage Program or benefit package, and it should be implemented by countries to establish, scale up, and strengthen their long-term care systems. This service package should be essential or priority for all countries, but of course, it should be depend on their contexts and local needs. This service package provides a set of services that can be delivered in various different settings by different professional care workers or even informal carers. This service package is being developed, but it has tentatively 3 different groups of interventions. The first one is services to facilitate person-centered integrated care. So it starts from older person-centered health and social assessment, which looks at individual needs and situation in a depth approach. And of course, the assessment should include carers' needs, who are usually their family members or volunteers, friends, communities. And also, there should be some needs for technologies or assistive products. And based on this comprehensive person-centered assessment, a care and support plan should be developed and used by a multidisciplinary team. And this person should be managed with proper case management and care coordination structure, where a care coordinator or someone should be in charge of coordinating between different cadres of workers. And the second group is to identify and manage older people's specific needs. So we have subcategorized those broad set of interventions into 4 groups again. First one is on health promotion and disease prevention. Second one is on supportive and assistive care, and palliative and end-of-life care. And finally, not just identifying managing older people themselves or individuals' needs. We also strongly emphasize that these interventions should include interventions to support carers' needs. The last category of intervention is education and training. So we have identified and listed certain aspects or components which informal carers or care professionals or proper care workers should educate and train themselves to provide optimal care to older persons. Finally, I would like to mention a few points that we expect the geriatrics and gerontology and the professionals in this field about their role for long-term care. The geriatricians and gerontologists are best placed to integrate and lead long-term care between health and social care systems. They may be experts in healthcare systems, but they have leadership and authority to refer and integrate between social care and services as well. They are also best placed to assess people's comprehensive needs with a person-centered approach. And this person-centered approach should not be limited to eligibility for or entitlement for service coverage or financing of care. They are best placed to coordinate different cases and patients, and they are collaborating with different health and care services and workers, and they could provide leadership and stewardship. They should be champions to support aging in place, although geriatricians or gerontologists may work in healthcare settings. They could support older people and carers reside and stay and live in dignity in their home and community-based settings. Finally, although they are working with other cadres, health workers, and care professionals, informal carers are also important manpower in providing optimal care. So geriatricians and gerontologists can understand caregiving needs, caregiving burden of informal caregivers, and should support them. Thank you very much.
At the conclusion of this panel, we can summarize what our presenters says. Dr. MIKTON show us how the global report of AAEs outlined the framework for action to reduce AAEs, including a specific recommendation for different actors, and bring together the best available evidence on the nature of the magnitude of AAEs, its determinants and its impact. It outlined what strategy were to prevent and counter AAEs and identify gaps and propose future lines on research to improve our understanding of AAEs. Dr. Thiago HERICK shows how age-friendly environment can be created by understanding the needs, setting priorities, planning strategies, and implementing them with the available human, financial, and material resources. And by leverage technology, investing in age-friendly urban and rural environment can enable other people with a wide range of capacity to age safely where they want to be. Dr. Yuka SUMI showed us how integrated care for older people, ICOP, reflect the continuum of care that will help to reorient health and social service toward a more person-centered and coordinated model of care to optimize physical and mental capacity in older age, and how WHO is supporting countries to adopt the integrated care for older people approach with a package of tools providing guidance for health and care workers in how identify, prevent, delay, and show down decline. At the end, our presenter number 4, Dr. Hyobum JANG, show us the WHO framework of long-term care and how WHO envision that every country should have a formal long-term care system to meet the needs of older people dependent of care, including social care and support that help them to daily living and personal care and enable them to maintain relationship, to age in place, which is a right for them, and to free them for elder abuse and to access to community service. Now we will get some questions from the audience, and we will please all the panel to try to answer them as much as possible. Thank you very much. Thank you very much for again for the opportunity and for organizers and the International Association of Gerontology and Geriatrics for the opportunity to have us here. For WHO is certainly very important, the opportunity to cooperate with in this process. So I got some comments and questions, and someone's in the chat that say that it's very important how to work in the age-friendly community and how get the citizens involved with that. There are some comments about Nora Keating is talking about communities vary and their capacity in supporting to older persons and community themselves may be marginalized and have limited resources. To what extent that has community capacity being part of the age-friendly conversation? I think that Thiago, I can extend to you the question, please.
Absolutely, Enrique, and I'm conscious of time, so I'll try and be brief. Many thanks for the question. Indeed, the capacity to respond to the needs and aspirations of older people vary across cities and communities, but we have amazing examples of cities and communities from all sizes, rural communities, remote communities taking action with some very creative solutions. Some of them do not cost much, most of them led by older people or with close involvement of older people. So there's a lot that is already being done and can be done regardless of the size or the maturity of your city or community. And once again, this is my presentation. I invite you all to have a look at the work that the members of the Global Network are doing and the practices that they are putting in place. They're amazing, they're inspiring. I encourage you to look at that and carry on the good work to turn your city and community more and more age-friendly.
Yuka, there is two questions that I think that we could relate it to ICO. One is from Malaysia. That the question is may I know if WHO provide training for social and gerontology individual to give brief structural therapy for depressive older adult? And maybe we could combine that with the question about how the geriatrician, the practicing geriatrician can address AAS as a problem. Please.
Thank you very much. Thank you very much for your important question. In terms of depressive mood is actually one of the intrinsic capacity we are addressing in the ICOP guidelines. So there is a screening and assessment how to intervene for the depressive mood for older people. And then WHO also has a MH gap guide addressing depression, the major depression itself. So it should be part of the assessment and management for older people. And in terms of the capacity building, we have many tools, implementation tools, for example, ICOP handbook app in different languages. And then I hope geriatricians can read the role to be part of the capacity or training workshop. Thank you.
Thank you, Yuka. And Hyobum, there is two questions for you. One is can you explain further why what that means that there is a mixed perception that the long-term care is too costly and endless, and there is also other question from Nora Keating about when thinking about long-term care, do we consider family cares as care workers who need the same kind of protection, benefit, and break from care work? Should we do this? Please, Hyobum, the chair is you.
Thank you very much, Enrique. For the first question about sustainable financing of long-term care, it is quite a widespread perception that long-term care is very costly in terms of especially government spending. So because of the population aging, that all the populations are, growing more, and there are less, younger populations who can provide, who can support the pension or social insurance system. That is a quite widespread perception. But we would argue that the older people and their carers, if provided a proper formal long-term care system and financing, they can also be less independent, more independent, and also contribute to the economy by participating to productive labor or behaviors contributing to the society and community. So maybe there could be a trade-off between the costly long-term care financing and also the possible or potential economic contribution by older people and caregivers that countries can consider. Secondly, about the informal caregivers or family caregivers, that's what we would like to also really emphasize as a part of our long-term care framework, that family caregivers should also given full attention, that they should be trained and educated, also provide support as a carers, working with other care professionals. But it is a reality that in many countries, or in most countries, they are not considered as formal workers yet, and they do not receive proper training, education, or support. So at least they are not, even when they are not considered education or support. So at least they are not, even when they are not considered or recognized or accredited as a former care workers, countries should start with measures to provide support for those family workers, which may include some kind of
at least they are
financial
not
incentives,
even
allowances,
when they are not
or
considered or
care.
recognized
Thank
or
you.
accredited as a former.
Well, I think that there is other question, but I think that we don't have any more time. Thank you very much for being part of this symposium, and we appreciate a lot. And in the name of WHO, we would like to say and reaffirm that the gerontology and geriatrics is an important and key factor in the development of the healthy aging decade. And we will hope that we will work together in every levels, in the country level, in the regional level, and the global level, together with the gerontology and geriatric societies, and of course with the International Association of Gerontology and Geriatrics. Thank you very much for the opportunity again, and see you soon.